During a post-cardiac arrest debrief, your team notes a drop in end-tidal CO2 from 35 to 10 millimeters of mercury during compressions. What is the most likely cause? A. High-quality compressions. B. Dislodged endotracheal tube. C. Effective return of spontaneous circulation. D. Hypothermia-induced low metabolism. Answer B. A sudden EtCO2 drop indicates loss of ventilation, often from tube dislodgement or severe perfusion failure. A 65-year-old male in cardiac arrest is found with a pacemaker. Defibrillation pads should be placed: A. Directly over the pacemaker site. B. At least 1 inch away from the device. C. Only on the anterior chest. D. Below the left clavicle. Answer B. Pads must be at least 1 inch (2.5 centimeters) away from the implanted pacemaker to prevent electrical interference or damage. Which condition best warrants immediate synchronized cardioversion? A. Sinus tachycardia at 130 bpm. B. Atrial fibrillation with stable BP. C. Unstable supraventricular tachycardia. D. Junctional rhythm with bradycardia. Answer C. Cardioversion is indicated when a tachyarrhythmia is causing hemodynamic instability, e.g., hypotension, altered LOC. A patient in PA has equal bilateral breath sounds and normal tube placement. Which reversible cause must be prioritized? A. Tamponade. B. Hypothermia. C. Hypovolemia. D. Tension pneumothorax. Answer C. In PA without mechanical obstruction signs, severe hypovolemia is the most probable cause of ineffective cardiac activity. During post-cardiac arrest care, what is the recommended target temperature range for TTM, targeted temperature management? A. 28 to 30 degrees Celsius. B. 32 to 36 degrees Celsius. C. 36 to 38 degrees Celsius. D. Below 32 degrees Celsius. Answer B. ACLS 2025 recommends maintaining 32 to 36 degrees Celsius for at least 24 hours to reduce neurological damage. When administering adenosine, the correct flush volume immediately after the drug is: A. 2 milliliters. B. 5 milliliters. C. 10 to 20 milliliters. D. 30 milliliters. Answer C. Adenosine must be followed by a rapid 10 to 20 milliliters flush to push the drug into circulation before degradation. Which waveform conformation best indicates correct ET tube placement during ACLS? A. Rising SpO2. B. Continuous waveform capnography. C. Chest expansion. D. Air entry on auscultation. Answer B. Continuous waveform capnography is the gold standard for confirming tracheal placement. What is the preferred route for ACLS medication administration if 4 access is unavailable? A. Intraarterial. B. Intramuscular. C. Subcutaneous. D. Intraosseous. Answer D. IO access provides immediate systemic absorption similar to 4 for emergency ACLS drugs. A patient in refractory VF has received shocks and amiodarone. What next? A. Give lidocaine. B. Consider double sequential defibrillation. C. Start dopamine infusion. D. Initiate synchronized cardioversion. Answer B. For persistent VF after multiple defibrillations, some advanced centers attempt dual sequential shocks. A sudden rise in EtCO2 to 45 mm of mercury during compressions may signify: A. Tube dislodgement. B. epinephrine overdose. C. Hyperventilation. D. ROSC. Answer, D. EtCO2 spikes indicate sudden improvement in circulation, a hallmark of spontaneous return of circulation. During post-resuscitation care, hypotension persists despite fluids. The next drug of choice is A. Atropine. B. Dopamine. C. Amiodarone. D. Adenosine. Answer, B. Dopamine supports cardiac output and systemic perfusion post-ROSC in hypotensive patients. A narrow complex tachycardia at 190 bpm persists after vagal maneuvers. The next step is A. Adenosine 6 mg rapid 4 push. B. Amiodarone 300 mg 4. C. Synchronized cardioversion. D. Epinephrine 1 mg 4. Answer, A. Adenosine is first line for SVT after vagal failure. What is the maximum cumulative dose of atropine for symptomatic bradycardia? A. 1 mg. B. 2 mg. C. 3 mg. D. 5 mg. Answer, C. Maximum recommended atropine dose is 3 mg. Beyond that, pacemaker support should be considered. Which electrolyte imbalance most likely causes torsades de pointes? A. Hyperkalemia. B. Hypocalcemia. C. Hypomagnesemia. D. Hypernatremia. Answer, C. Low magnesium destabilizes cardiac electrical activity, leading to polymorphic VT. The main goal during post-cardiac arrest ventilation is to maintain PaCO2. A. 20 to 25 mm of mercury. B. 35 to 45 mm of mercury. C. 50 to 60 mm of mercury. D. Below 30 mm of mercury. Answer, B. Maintaining normic apnea prevents cerebral vasoconstriction and ischemic injury. What's the first action after identifying PA on the monitor? A. Defibrillate. B. Begin high-quality CPR. C. Give adenosine. D. Administer lidocaine. Answer, B. PA is non-shockable. CPR and addressing reversible causes are priorities. Which sign most accurately predicts poor neurological outcome after cardiac arrest? A. Fixed dilated pupils. B. Low EtCO2 during CPR. C. Absent corneal reflex after 72 hours. D. Bradycardia during hypothermia. Answer, C. Persistent absence of brainstem reflexes after 72 hours strongly correlates with poor prognosis. Which drug can worsen hypotension in post-ROSC care? A. Epinephrine. B. Dopamine. C. Amiodarone. D. Adenosine. Answer, C. Amiodarone can cause vasodilation and negative inotropic effects, which may lower blood pressure. A patient in VF is given an incorrect synchronized shock. What is the likely consequence? A. Improved outcome. B. No effect. C. Induction of asystole. D. Worsened fibrillation. Answer, D. Synchronizing during VF is inappropriate and can worsen the arrhythmia. In a bradycardic patient with second-degree type 2 block, atropine fails. Next intervention? A. Epinephrine. B. Transcutaneous pacing. C. Adenosine. D. Nitroglycerin. Answer, B. Pacing is indicated for high-grade AV block unresponsive to atropine. Continuous chest compressions with asynchronous ventilations are appropriate when A. Advanced airway is placed. B. Pulse is present. C. No fore access. D. ROSC achieved. Answer A. Once an advanced airway is inserted, compressions continue without pause for ventilations. Which rhythm requires immediate unsynchronized shock? A. VT with pulse. B. Atrial fibrillation. C. Ventricular fibrillation. D. SVT. Answer C. Unsynchronized shocks, defibrillation, are reserved for pulseless VF/VT. A patient in cardiac arrest has a PECO2 of 12 mm of mercury after 5 minutes. What should be done? A. Stop CPR. B. Check pulse. C. Improve chest compressions. D. Start vasopressin. Answer C. EtCO2 less than 10 to 15 mm of mercury suggests ineffective compressions. Which vasopressor is preferred if norepinephrine causes arrhythmia post-ROSC? A. Vasopressin. B. Dopamine. C. Epinephrine. D. Phenylephrine. Answer A. Vasopressin raises blood pressure without increasing heart rate, reducing arrhythmia risk compared to norepinephrine. When defibrillating through a wet chest, you should first A. Increase shock energy. B. Dry the chest quickly. C. Use double shocks. D. Change to manual defibrillator. Answer B. Moisture can divert electrical energy and cause burns. What should be done immediately after delivering a defibrillation shock? A. Recheck pulse. B. Confirm rhythm. C. Give amiodarone. D. Resume CPR. Answer D. Resume CPR immediately after shock. Don't check pulse until 2 minutes later. What is the primary advantage of waveform capnography during CPR? A. Measures heart rate. B. Detects perfusion quality. C. Confirms fluid resuscitation. D. Prevents bradycardia. Answer B. It provides real-time feedback on perfusion and compression effectiveness. Which drug is contraindicated in pulseless electrical activity? A. Epinephrine. B. Lidocaine. C. Amiodarone. D. Atropine. Answer D. Atropine is no longer recommended for PA or asystole. Which of the following is a correct indication for sodium bicarbonate use during ACLS? A. Cardiac tamponade. B. Prolonged cardiac arrest with severe acidosis. C. Early PA. D. VF arrest. Answer B. It's used only in specific conditions like metabolic acidosis or tricyclic overdose. What is the preferred energy setting for biphasic defibrillation? A. 100J. B. 360J. C. 300J. D. 120 to 200J. Answer D. Most biphasic defibrillators are effective between 120 to 200J for the first shock. You're leading a resuscitation where the rhythm changes from asystole to fine VF on the monitor. What should be your next immediate action? A. Increase oxygen concentration. B. Continue CPR and prepare to defibrillate. C. Administer atropine. D. Stop compressions to confirm rhythm with 12-lead ECG. Answer B. Fine VF should be treated as VF, continue compressions and prepare for defibrillation. Pausing CPR risks losing the shockable window. A 70-year-old post-cardiac arrest patient shows a map of 58 millimeters of mercury despite norepinephrine at 0.2 micrograms per kilogram per minute. Which next step optimizes perfusion? A. Add vasopressin. B. Start dobutamine. C. Give 4 fluids rapidly. D. Reduce norepinephrine dose. Answer A. Vasopressin augments vasoconstriction without increasing heart rate. It's effective when norepinephrine alone is insufficient. During synchronized cardioversion for atrial fibrillation, the patient suddenly develops VF after the shock. What's your next step? A. Deliver a synchronized shock again. B. Begin chest compressions and defibrillate immediately. C. Give adenosine. D. Increase sedation and repeat. Answer B. If VF occurs after cardioversion, treat it as cardiac arrest, start CPR and defibrillate unsynchronized immediately. A patient in cardiac arrest receives multiple doses of epinephrine. ROSC occurs, but severe hypertension, BP 210/110 mmHg, follows. What should be done first? A. Administer beta blocker immediately. B. Stop epinephrine infusion. C. Begin rapid cooling. D. Give additional fluids. Answer B. Hypertension post-ROSC often results from excess catecholamine effect. Stop epinephrine and reassess before introducing antihypertensives. A 56-year-old post-cardiac arrest patient is comatose. EEG reveals burst suppression pattern. What is the immediate management goal? A. Initiate therapeutic hypothermia. B. Increase ventilation rate. C. Begin high-dose barbiturates. D. Prepare for brain death testing. Answer A. TTM at 32 to 36 degrees Celsius helps limit further cerebral injury after cardiac arrest in comatose survivors. In an intubated cardiac arrest patient, the ETCO2 reads 7 mm of mercury despite good compressions and correct tube placement. What is most likely true? A. ROSC is near. B. Perfusion is severely inadequate. C. The tube is in the esophagus. D. The patient is hyperventilated. Answer B. Low ETCO2 indicates poor circulation or ineffective compressions, not tube misplacement if waveform remains consistent. Which ACLS drug should be avoided in patients with polymorphic VT due to prolonged QT? A. Magnesium. B. Epinephrine. C. Lidocaine. D. Amiodarone. Answer D. Amiodarone prolongs QT further and may worsen torsades. Magnesium is the correct treatment. You are preparing to give an epinephrine dose during a code, but the 4-line infiltrates. What's the correct next step? A. Inject epinephrine intramuscularly. B. Continue CPR and obtain IO access. C. Administer via endotracheal tube. D. Insert a peripheral line in the same arm. Answer B. IO access is the immediate alternative for rapid, reliable drug delivery when 4-access fails. After ROSC, the patient's oxygen saturation is 100% on 100% FiO2. According to ACLS 2025, what should be done next? A. Maintain FiO2 at 100%. B. Gradually titrate FiO2 to achieve 94 to 98% SpO2. C. Extubate immediately. D. Begin hyperventilation. Answer B. Excess oxygen post-ROSC can worsen oxidative brain injury. Titrate to 94 to 98% for controlled oxygenation. A patient with suspected tricyclic antidepressant overdose develops cardiac arrest. What drug is most indicated? A. Sodium bicarbonate. B. Amiodarone. C. Magnesium sulfate. D. Lidocaine. Answer A. Sodium bicarbonate corrects QRS widening and counteracts TCA-induced cardiac toxicity, making it life-saving in these arrests.